Greetings, everyone. We are having trouble with that link going in and out on you that I recorded the other night for the ICU medications, and we lost power in the middle of that anyway. So I am going to re-record all of that on YouTube just to make sure you have it for the exam. I don't want anyone having extra anxiety put on you. So I have, you'll need to get your PowerPoint out with common medications used in CCU ICU unit. And I have also, when you finish looking at this, I have posted a quiz for you to take that if you go by that, it won't be the same questions, but it'll be very similar. So if you know the right and wrong answers to those, it will help you. And then I've also posted the answers in a separate email. So do it first, then check your answers. All right, so let's get started. If you go to, I don't want that, sorry. Let me go find my PowerPoint because I had closed it out. Sorry about that. ICU content, and then my PowerPoint on ICU common meds. Here we go. All right. First one, Nipride, also known as Nitroprusside. This relaxes both the arterial and the venous muscles. And what does it do? Lowers blood pressures quickly. So Nipride works quickly. And what does it quickly reduce? Hypertensive emergencies. It reduces the preload and the afterload. You do prefer to have an art line in place, and you'll remember if you listen to my lecture, an art line helps monitor blood pressure, right, invasively, so that you're getting a very accurate reading. Remember the typical waveform, and I went over the parts of the waveform. So the art line is imperative that you have in place with someone on Nipride, because if that's going to drop it real quickly, you want to be able to tell real quickly. So they'll set alarms for certain parameters, and it will go off if it drops below that and alert you that they are dropping too quickly. You're going to mix it in 50 milligrams and 250 of D5W, or premixes are available, but either way we protect it from the light by putting a brown bag over it. Now, one of the things about Nipride is that it can trigger sodium and water retention. So what are you going to watch for? Someone's on a Nipride drip, always watch for what? Fluid retention. You're going to be checking for edema. You're going to be listening to their lungs. You're going to be checking their weight. You're going to be monitoring their INO, right? Right. The starting dose is 0.1 mics per kilogram, and that can range from 0.1 to a max of 5. I have seen it go a little bit higher, but if you start going above that, you got to be very careful about this next thing. It says excessive doses of Nipride can also cause cyanide and thiocyanate toxicity. So why could Nipride, how could it cause cyanide toxicity or thiocyanate? Well, first, thiocyanate is a byproduct of cyanide, so that's where that builds up. And the reason that is the way that it is if you go back and look at the molecule of Nipride, for each molecule of Nipride, it contains 5 cyanide molecules. So now that's why when it starts breaking down and you've got too much of it, you can get into cyanide and thiocyanate toxicity. What's the number one thing to watch for? Profound hypotension. Well, we already know what does Nipride do? Drop the blood pressure and drops it quickly. So it's real easy to get confused. Is it because they're getting too much Nipride that it's dropping it, or is it related to them getting too much in their cyanide poisoning? So make sure that you're someone on long-term Nipride and they start having profound hypotension with these other signs and symptoms: metabolic acidosis, shortness of breath, headache, ataxia, vomiting, loss of consciousness, and psychotic behavior. They will start having some psychotic behavior as well. These are all signs and symptoms of toxicity of cyanide and thiocyanate, so you would want to notify the physician. One of the things you want to make sure you know, this is a list, so anytime there is a list, I'm thinking what? Select all that apply. Monitor blood pressure again carefully. Our nursing considerations for Nipride: electrolytes, particularly sodium, because why? We can have sodium and water retention. Check weight, INO, edema, and hydration. Why? Because of the sodium and water retention. and if they're on it long-term, monitoring for cyanide and thiocyanate levels. Alrighty then. Our next one is Diprivan or Propofol. This is used as a sedative hypnotic. It is used for patients who are intubated mechanically, and it has a very short onset and half-life, which is a good thing. It means we take it off and it doesn't last long, it goes away. You want to again take their blood pressure and respirations every 15 minutes till stable or while you're titrating, and then every 30, and that's common. 15 while you're titrating, 30 thereafter. The patient will be allowed to wake up every AM daily to monitor their neurostatus. So you can make them come off the Diprivan, make sure their neurostatus is doing okay, and then you can put them back in their comatose-like state. It comes pre-mixed. You want to make sure, one of the things, anytime you're giving Diprivan, that they have a high risk of bacterial infections associated with it. So you want to discard open vials within 6 hours, and I'll tell you why on the next slide. Tubings are also changed every 12 hours instead of every 12 shift because it does cling to the inside of the tubing as well and increases that bacterial infection or potential for. Initiation of sedation begins with 5 mics per kilogram or higher, and you can increase that by 5 to 10 mics over 5 to 10 minutes until the desired response. Now, you're going to be assessing anyone that is on Diprivan. You're going to be assessing their IV site. All of these can be kind of cause tissue necrosis, their respiratory status, their neurostatus daily or per protocol, and again, high risk of bacterial infection. So monitor for signs and symptoms of infection. So why are we discarding these vials? Why does someone on Diprivan at increased risk for bacterial infection? Well, the drug itself is mixed with soybean oil, glycerol, which is, we know, sugar, and egg lecithin, which is that yellow brownish fatty substance. So you can imagine yellow brownish fatty substance, glycerol, sugar, and soybean oil. That sounds like an excellent medium for bacterial growth. So again, changing that out per protocol or every 6 hours of an open vial is very important. All right, the next one is Dobutamine, which is not our first drug of choice for hypotension to increase blood pressure, but it is a drug available if we need it. This directly stimulates beta-1. Beta-1 we know is the heart because we only have one heart. Beta-2 receptors would be the lungs because we have 2 lungs. So it works on the heart to increase contractility and stroke volume. Comes pre-mixed. Again, we're going to take our blood pressure per that pretty common protocol of every 15 minutes while titrating, and then every 30. We want to closely monitor patients for heart rhythms in that IV site, so that's why it can be tissue necrotic, so we give the central venous line. We do prefer on most of these drips that a patient is given all of these drips through central venous line because of the potential of tissue necrosis. With this one, the normal range is 2.5 to 20 mics per kilogram per minute. If you're going to increase this, of course, you would start a lot of times with 2.5, and then you increase it 1 mic per kilogram per minute. So if 2.5 was not working, you would go to 3.5 the next time, and then 4.5. And how often do you increase that depends upon the patient and the protocol where you work. You want to monitor for ectopic beats and tachycardia. Low-dose continuous infusion is given for someone with heart failure. And again, it is not the first line of drug for hypotension. So we give this more of a second or third line drug. On the other hand, dopamine is given also for hypotension because it has inotropic or contractility power, increases the heart rate, and has vasoactive properties, and then it vasodilates. Now, this one is effective in improving perfusion, correction of hypotension and shock, and also helps with bradycardia. It comes mixed or pre-mixed, same scenario with your vitals, every 15 while titrating, and then every 30. With this one, the dose again is 2.5 max initially up to 20, but instead of increasing it only by 1 mic per kilogram per minute like we were doing on dopamine with Dobutamine, with dopamine we increase the rate by 5 mics per kilogram. So if 2.5 was not working, then the next time they would get 7.5 and so forth up to 20. Now, the big thing you have to remember with this one is the patient has to be well hydrated for it to work. So with a lot of these medications that you're given for hypotension, you will always see the nurse giving a fluid bolus ahead of time to make sure that patient's well hydrated so that the drug works well. You also want to monitor for ectopic beats, tachycardia, and tissue necrosis. Again, that's why we prefer to have central lines. So you got a patient on a dopamine drip that's not doing well. You're up to 20 mics per kilogram. Always check the hydration status. All right, amiodarone is an antidysrhythmic. It's a complex agent. It does have effects on your sodium, potassium, and calcium channels, so you want to monitor your electrolytes. It has alpha and beta adrenergic blocking properties and can lead to toxicity. The loading dose for it is quite complicated, really. You don't have to know this extreme loading dose here. 150 and 100 mils of D5W over 10 minutes, then 90 to run at 1 milligram per hour. Then for the next 6, 0.5 per hour, and then for the next 18. So also you'll usually have a protocol on how to give this, and it's given in a glass bottle. With this one, you're going to check blood pressure every 5, then every 15, and then hourly. So this one's a little bit different, or per protocol. The oral dose should always be given prior to stopping the drop factor or the drip and converting over to the pill. Alrighty, nitroglycerin. Of course, someone comes into the ER, we're going to give nitro sublingual. We're going to give up to 3 tablets every 5 minutes. But for long term, they can start them actually on IV form of nitroglycerin drip. This reduces cardiac oxygen demand, preload and afterload, and increases blood flow so that it increases and helps treat angina or chest pain. It's mixed in 50 milligrams of 500 to D5W in a glass bottle as well. The dose is a little bit extreme here, it seems like, but it's really not. 5 mics per minute, titrate up to 100 mics per minute, and you have to follow protocol on how much to titrate. A lot of times you increase it by 5 mics per minute. You want to monitor blood pressure and heart rate, and check the blood pressure every 15 minutes while titrating, and then every 30. Norepinephrinel Levophed has potential vasoconstrictor with additional inotropic properties in that it increases the strength of contractility. We know inotropics are either positive or negative. If they're positive, they increase strength. If they're negative, they decrease the strength of contraction. So in this case, if we're treating hypotension, we wouldn't think that would increase strength, so it's positive inotropics. This is used to treat hypotension associated with shock, sepsis, and anesthesia. 8 milligrams and 250 of D5W is your starting dose at 2 mics per minute, and titrate up to 30. Of course, we're going to have to monitor blood pressure and heart rate. If they're hypovolemic, treat that first. Anything you're giving blood pressure medicine, if they're hypovolemic, always give a fluid bolus to treat that first so the med can work better. Tissue necrosis can also occur if this one infiltrates, so another reason to have a central venous line or a PICC line. Again, check your blood pressure, this one every 5, while titrating every 15, and then every 30 once stable. All right, and that's the end. Not much to it. You can do it. Thank you. If you have any questions or concerns, please let me know. Thank you very much.